السلام عليكم. أنا دكتور جهاد. حنتكلم اليوم عن محاضرة الهايبرتنشن. قبل ما نبدأ حتكلم لكم في البداية عن أو خلينا على طول نبدأ، بعدين حقول لكم الأشياء اللي أبغى أقول لكم. هنا تتكلم إن البلد بريشر عبارة عن الكاردياك أوتبوت ضرب البريفرال ريزيستنت، فكمية الماء اللي طالع أو الدم اللي طالع من الهارت ضرب البريفرال ريزيستنت. البريفرال ريزيستنت هي اللي أصلا تحافظ على البلد بريشر عندك. فلو أنت ضغطت أي شيء، مثلا ضغطت الماء داخل البالون فيه مثلا نقب صغيرة، هذه هي اللي فكر فيها، عبارة عن النقب الصغيرة. هذه هي البريفرال ريزيستنت، هي اللي تخلي الدم يظل داخل الارتريز ويسوي لك بلاد بريشر. فلو صارت الفتحات هذه كبيرة، اللي هي عبارة عن الكابيلاريز في حالتنا، لو صارت الكابيلاريز هي very small، لو صارت very big زي مثلا in case of septic shock، السيتوكاينز تخلي الأوعية الدموية تتوسع، فيصير عندنا low blood pressure. فهنا المشكلة في السبتك شوك، إن حتى لو عطينا lots of fluid sometimes، حتى لو عطينا vasopressors اللي تخلي arteries to contract، it's still not enough to maintain the blood pressure sometimes, because we cannot control the peripheral resistance. So as we said, blood pressure equals cardiac output, which means cardiac output per minute. And cardiac output is stroke volume, how much I am pumping per one beat, multiplied by the heart rate. So if I'm beating, for example, just an example, if I'm beating 1 liter per one pump or one contraction, and I'm doing 80 beat per minute, so I'm pumping 80 liters per minute, because I'm pumping 1 liter per pump, and I'm doing it 80 times. Here, as we said, the blood pressure, even us as doctors, we control the blood pressure either by controlling cardiac output or by controlling the peripheral resistance. So what's hypertension? It's elevated blood pressure. Here I want to talk, as I first said, that we have two different schools. We have the American schools, which is the ACC, American College of Cardiology, which the doctors seems to like more, or having it as the main source of guidelines. We have the British guidelines, which is still uh, taking the old pictures. So before we, in the American guidelines and the European guidelines, they both of them, they agreed that having blood pressure of 140 to 90 over 90 is considered the first stage, or stage 1 hypertension. From 130 80 to 140 90, this is pre-hypertension. It means that it will not affect the mortality and morbidity of the patient. So there comes by one of the largest pharmacy companies. She did a big study that shows lowering blood pressure even further to less than 130/80 will reduce the mortality and morbidity by, as I remember, it was by 5%. So taking this in consideration, the American Society, they changed the goal for blood pressure or normal blood pressure to less than 120/80, and they started having or calling someone with high blood pressure, and as we said here in stage 1, from 130 he's hypertensive, from 80 and more he is hypertensive. So as we said, this is the American guidelines. We have the normal less than 120/80, pre-hypertensive between 120 to 129, but the diastolic is less than 80, stage 1 and stage 2. Based on average of 2. اوكي، يقول لك هنا انك لازم تاخذ 2 measures، تاخذ ال average of these 2 measures. These 2 measures must be at least 1 to 2 minutes apart. To have, and you take the mean، يعني النص مثلا طلع لك 130 و 120، تاخذ الرقم اللي في النص بينهم اللي هو 125. This is an office reading. Type of hypertension, it's either essential, primary or secondary hypertension. Most cases are primary hypertension, so no underlying cause, but we have risk factors. These risk factors, it will get you more prone to have hypertension. Like if you are obese, you are having more chance to get hypertension, primary hypertension, than a lean patient. If you have diabetes, you are more likely to have hypertension. If you have dyslipidemia, you are more likely to have hypertension. If you have sedentary lifestyle, you are inactive, you don't do exercise, you are more likely to have primary hypertension. Secondary means there is a cause for this hypertension. So accurate blood pressure measuring, you have to be in either time, as we said, it has to be in the morning, it's the best time, but you have either the morning or the night. Why we are having these differences, either the morning or the night? Because you have the biological clock, you have ساعة بيولوجية عندك which secrete cortisone in the morning إذا نومك مزبط، يعني إذا نومك كويس. فالcortisone is one of the factors that raises the blood pressure. So it's unfair to measure the blood pressure at night where the cortisone is very low and you have it as your usual blood pressure. So it's best to have it in the morning, and even in the night is important, but not as much as the morning. So the position, either sleeping position or sitting position, is fine. Standing position, we usually do it only to assess for orthostatic hypotension. Orthostatic hypotension, it's the first sign of dehydration. So if a patient come to me in the ER having diarrhea or bleeding per rectum, for example, and I want to assess his volume status, I will ask for sitting or sleeping and standing position, and I will request blood pressure monitoring for every position of these. Having systolic blood pressure drop after 1 to 2 minutes of standing. For example, if he had 140 in the sleeping position systolic blood pressure and he had 120 systolic blood pressure, so more than 20 millimeter drop in the systolic blood pressure, this is diagnostic of orthostatic hypotension. Or you want to have the diastolic less than 15 millimercury. So you have to stop smoking 5 minutes before. Physical activity must be stopped 20 minutes before. 10 10 to 20 minutes is fair. Coffee, must not drink coffee 5 minutes before. Size cup here, I disagree with this. Um, we don't have to measure اللفات length كامل. We only measure the bladder of the calf. So what is the bladder of the calf? I have one picture here. This is the bladder of the calf. The circumference of the hand, محيط الهand, must be, and you measure it, and you measure the length of the bladder of the calf. This at least must be 80% of the circumference, 80 to 100% of the calf, and the width, العرض, must be at least 40% of the circumference of the hand. If you have less than 80%, let's say 50%, you have to inflate it more to occlude the artery. So you will have false high blood pressure because you need to inflate it more and more and more. And if you have larger than 100, you have to inflate it less to occlude the artery. لأن افرض انت لفيت هذا مرة وزائد عليه 20%، فال20% حتنتفخ من جهتين، فتصير في جزء منها 40% منتفخ، ف you will occlude the artery easier، ف you will give you false low blood pressure. Okay, so the method, as we said before, the patient must be in the sitting position, must have been rested, the cuff size must be good, the bladder must be, you have the measurement of your hand circumference, and the bladder length must be at least 80% of the circumference, and the width is 40%. And the cuff must be at the same level as the heart, and then you measure it. Then you will put the stethoscope in the brachial artery space and you will listen. What you are going to hear is something called Creutzfeldt sound. There are 5 stages of this sound. Okay, I will take you through it. So the first sound that you are going to hear is the first Creutzfeldt sound, and this is the systolic blood pressure. So what is the systolic blood pressure? Is when the heart is compressing and contracting, it pumps the blood out of your heart, and this will create pressure. The highest pressure that will be reached is called systolic blood pressure in the artery, of course, and the lowest pressure in the arteries is called the diastolic blood pressure. So the systolic blood pressure when the heart is contracting, and the diastolic blood pressure is when the heart is relaxing. The first heart, the Creutzfeldt sound is the systolic, the beginning of the systolic, and the first or the beginning of the fifth Creutzfeldt sound is the diastolic blood pressure. Pulse pressure is the difference between the systolic and diastolic. So 120 minus 80, it's 40. And this is called pulse pressure. We have many causes of something called wide pulse pressure. It must be not exceeding 40. So we have wide pulse pressure in many cases, like if we have elderly patient, because we have stiff arteries. The arteries are stiff. So it's not compliant, it's not elastic um, to a little bit expand and have the blood pressure low. So I will give you one example why this is important, because um, the American guidelines says with elderly patient more than 70 years old, uh, because of this physiological problem, if he has systolic blood pressure high and diastolic is normal until 140, 150 even sometimes, we don't treat because it's physiological and does not correlate with mortality and morbidity, and it's only one study, so we must confirm it by different studies and cohort study and systemic review later on. Mean arterial pressure, this is calculated by تاخذ 2/3 of the diastolic blood pressure, 2/3 وتضيفه زائدا 1/3 of systolic blood pressure. This is important especially in ICU patient and CCU, because if someone have shock and like septic shock and we are giving him a pressor, we need some kind of a goal to have whether to increase these vasopressors, we give more vasopressors, we need to give more vasopressor or not. This is the mean arterial pressure. We need to keep it above 60 in ICU and CCU patient. Why 60? Because most vital organs like brain needs at least 60 mean blood pressure to be perfused. So in order to have enough blood to come to it, like the heart and the brain, they need at least 60 MAB. We call it MAB, mean arterial pressure. This is the ACC guidelines, the American guidelines that we talked about. And as we said, to diagnose blood pressure, we need at least two um, two measures at least in two different occasions to diagnose. And we have other elements like we have the ambulatory blood pressure and we have the home monitoring. Ambulatory means we give you the device and it by itself will take your blood pressure every 15 to 30 minutes and will give an average uh, blood pressure. So the American says if it's more than 130 daytime only, not we do not include that the nighttime. If the daytime blood pressure is more than 130/80, we diagnose blood pressure. This is by American guidelines. By British and European guidelines, it's 135 daytime over 85. So here in the lecture, she is taking the American. So if the ambulatory blood pressure is more than 130 over 80 daytime, which is the best thing to do, this is correlate with high blood pressure. So isolated systolic blood pressure means the systolic is high and the diastolic is normal. And this is mostly comes with elderly people, as we said, because of calcification or patient with prolonged hypercalcemia, because it will calcify the arteries. And these, they are having isolated systolic blood pressure. We have the white coat syndrome or white coat hypertension. This is when a patient is nervous or he knows that you are going to take his blood pressure. So he is a little bit nervous, and with nervousness and worrying a little bit, his blood pressure will go a little bit up. Here it says it's impossible to diagnose white coat hypertension if the systolic is more than 160 over 100, and I disagree with this. If it's more than 160 over 100 and you have end stage organ damage, like you have hypertrophic cardiomyopathy, or you have renal injury and eye injury, then you are correct. You cannot diagnose white coat hypertension. But if there is no end stage organ damage, you cannot diagnose it. If he has systolic blood pressure more than 180 and diastolic blood pressure of more than 120. So 160, 100 and end organ damage, we cannot diagnose it as white coat hypertension. This is hypertension. If it's more than 180 over 120, this is not white coat hypertension. Home monitoring, we give you the device, we teach you about the device, and we ask you to take your blood pressure every it must be at least 12 reading per 24-hour. The readings, we do this because we can do it extended amount and extended period of time. نعطيك إياه تقريبا 3 months. Every month you have to measure your blood pressure for a week. يعني الأسبوع الأول من كل شهر. Let's say the first week of every month. You measure your blood pressure every 2 hours, and we have the mean over this period of time. كل أسبوع كل شهر 3 مرات، كل شهر مرة، كل شهر أسبوع you take your blood pressure. So this is to have appropriate and more specific diagnosis of hypertension. So it's extended time and avoid white coat hypertension diagnosis, and we can measure it at any time, but must be, as we said, 12 readings, so every 2 hours, and this is predictive actually of cardiovascular mortality and morbidity, and we can diagnose white coat syndrome if it's normal and in the office it's high. We have modifiable risk factor and unmodifiable risk factors. The non-modifiable, that we cannot change. It will happen regardless of what we do. So age and gender and genetic factor, we cannot, and ethnicity, we cannot control these things. The modifiable, we can control them. So here, regulatory mechanism to the blood pressure. We have the baroreceptors. We have 2 baroreceptors. We have the carotid baroreceptors and we have the aortic baroreceptor. What does that mean? Baroreceptors, these are stretch or stress or high blood pressure sensor. So when the vessels are stretching because high blood pressure, these will be activated. Okay? So what they will do, both of them will send the message to the brain, the medulla especially, and here the aortic baroreceptor will send the impulse by the aortic depressor nerve to the brain. The brain will do 2 things. This will go from the medulla to the vasomotor center. Vasomotor is the one controlling the contractility of the arteries. So this will go to the spinal cord and will cause vasodilator if it's high blood pressure. And will cause low and will stimulate the vagus nerve to have more acetylcholine, and the acetylcholine will depress the heart, so will cause the heart to have less heart rate and less strong, which means weaker contraction as well. And there is also baroreceptor found in the veins, but these are mainly for hypotension, um, not hypertension. So in the artery, these baroreceptors for sensing more of hypertension to act, and in the veins they are more to sense hypotension. So if there's hypotension, this will send the impulse to the brain and will contract the uh, the veins, and will give, because the vein has more volume, more blood. With contraction, it will reach the artery in a faster way, in a better way, and in a larger volume. And this will be done by activating the sympathetic system. So sympathetic system will cause contraction of the veins and will give more fluids in the artery and will raise the blood pressure. Here, as we said, it's negative inotropes by these baroreceptors will cause the vagus nerve to secrete acetylcholine, and this will do negative inotropic, which means weak contraction, and negative chronotropic effect, which means slow heart rate, and will go to the vasomotor center and will cause vasodilation, and this will reduce the blood pressure. And we have here a better mechanism that we explained in the previous lectures about the RAS system, renin, angiotensin, aldosterone system. You can go to that lecture and listen to it. We have, as we said, essential and secondary blood pressure. We talked about the primary. Now we go to the secondary hypertension. When do we suspect this is a secondary cause of hypertension? If it's resistant to medication, if it's abrupt. So let's say last week your blood pressure were normal and now you have hypertension. So this is abrupt hypertension. It means mostly there is something wrong going on. And if you have hypertension at less than 30 years old, we have to suspect it, exacerbated of previous controlled hypertension, and if it's disappropriate, means that if we have tissue organ damage, it means, let's say we have a blood pressure of 150/90, and you have a kidney failure because of hypertension. We should suspect that the kidney failure is the one causing the high blood pressure, not the vice versa, not the opposite. So why is that? Because we don't expect a blood pressure of 150 to cause renal failure, for example, or 140 to cause renal failure, unless it's very prolonged time and it's unmanaged. As we said here, when to suspect it, if resistant to medication, sudden like 180/20 over short period, and okay, causes of secondary renal disease, renovascular disease like renal artery stenosis, primary hyperaldosteronism, and obstructive sleep apnea. And this is usually missed if someone is obese and it's uncontrolled and malignant hypertension for medication, not controlled. We suspect that maybe he has obstructive sleep apnea, and that's causing his non-controlled hypertension. Drug like in female, if she is taking hormonal therapy or contraceptive therapy, that will cause complication of hypertension to the heart. It will cause left ventricular hypertrophy. ليش can cause left ventricular hypertrophy? Because you are exercising it, you are putting more load to it. Imagine you are going to the gym every day and having you take lots of weight, eventually your muscles will get larger. And same goes with the hypertension. With a prolonged period, your muscles will grow to accommodate for this afterload. The afterload is the pressure from the systolic and diastolic pressure. So, because the afterload is high, you will build more muscles, and these muscles, the problem with it is you have more muscles, but the arteries or the uh, nutritional value of the arteries are the same. So imagine you are having these muscles, and these muscles are supplying, let's say, 1 kilogram of muscles. When this grows to 3 kilogram or 2 kilogram, same vessels that were supplying only 1 kilogram of muscles now are supplying 3 kilogram. So they are making you more prone to angina, more prone to even MI. So left ventricular failure because less supply to the heart, as we said, and decreased perfusion, same as we said here. It's the same as we said. And yes, we have more atherosclerosis with hypertension because the endothelium will get inflamed by high blood pressure, and will make it more prone to atherosclerosis. And this also will make you more prone to aortic dissection, of course, with high blood pressure. CNS, because you are doing atherosclerosis, of the capsule, here's the capsule or the capsid of the atheroma. If it's weak like this one, it's more easily to rupture with high blood pressure. And if it's rupture, it will cause inflammatory cascades and will secrete platelet aggregation factor, and this will aggregate the platelet and will cause thrombus and eventually will cause stroke, ischemic stroke. This ischemic stroke could transform to hemorrhagic stroke, and even hypertension, because the small capillaries could not tolerate this high blood pressure and could rupture and could cause hemorrhagic stroke. Renal complication, as we said before, if you have the RAS system uh, lecture, if you attended it, you know that the kidneys has this Bowman's gland, or the Bowman's capsule, uh, and this capsule uh, is taking the filtered amount of fluids, and when you have high blood pressure, this will make the capsule having more pressure, and this will cause damage to the capsule and will cause kidney failure. Here we talked about them in details, why it's called the silent killer, because sometimes you don't have any symptoms and you have very big or numbers of blood pressure and you will not feel anything. That's why we should screen for it. Sometimes you have only morning headache, and that's because the map in the brain is going higher than what it should be. Here's the symptoms of hypertension. You can read it. Sometimes they are not common symptoms unless you have something. So hypertensive crisis, we have two things. We have hypertensive urgency and we have hypertensive emergency. Hypertensive urgency means there is no target organ damage, there is no stroke, there is no pulmonary edema, there is no hematuria, there is no bleeding in your eye, and um, even sometimes nosebleed, if it's a non-stop and you can't control it, we call it hypertensive emergency. So urgency, no organ damage, and you have very high systolic, more than 180, and the diastolic is more than 120. Why we are saying urgency and emergency? Because the treatment is different. With urgency, we give you oral medication like captopril, cabotine. We can give nifedipine uh, for you to control your oral medication, but not sublingual nifedipine, only oral nifedipine, because sublingual will cause really high fluctuation of heart of blood pressure, and this will cause a really problem. Will decrease the perfusion to the heart. Uh, yes, I should mention this. With hypertensive uh, urgency, we do not decrease the blood pressure in few seconds. It's not correct. I have seen this in many emergency rooms. You come with high blood pressure, they give you everything, capotine, nifedipine, Lasix, to decrease the blood pressure, and this is wrong. This could end up with stroke, because as we said, there's a regulatory mechanism for the uh, for the brain, for the heart, and the map must be from 60 in the brain, for example, from 60 to 160 map, mean arterial pressure. With this, if you have this hypertension, this will raise the perfusion or the map of the mean arterial blood pressure to the brain to protect itself. So, for example, it will be from 100 to 180 or 200. And if you decrease it to less than 100, this will cause less perfusion to the brain, and this will cause stroke. So you need to be careful and lower the blood pressure gradually. With emergency, as we said, if you have MI, if you have seizure, if you have nausea, vomiting, if you have hematuria or AKI, this is emergency. And the difference is we give IV medication. We give netroproside here, or IV labetalol, for example, to treat this patient. We don't give oral because we don't have time. As we said here, we have discussed this. If it's urgency, oral medication. If it's emergency, we have top emergency if we have aortic dissection or severe preeclampsia or eclampsia to the patient, or pheochromocytoma crisis. We lower immediately because these will be really affected by the blood pressure. We lower it below 120. So if you have aortic dissection, you go directly to less than 120, or pheochromocytoma or severe, because pheochromocytoma crisis come abruptly. So there is no time for the brain to adjust its map. So we go to our goal to go to less than 120. Severe preeclampsia and eclampsia because it has more mortality and morbidity to the mother and the baby. Otherwise, if these are not the causes of the severe high blood pressure, we reduce it by 25, 20 even in the first hour, and then gradually over 2 to 6 hours, we go to less than 160, 110. Then over next 1 to 2 days, we bring it down to less than 140, 90. And then we prescribe oral medication for the patient because he is diagnosed now with hypertension. Uh, okay, the patient. I think we talked about these things before. and this is the quiz, and good luck for everyone. I hope you like the lecture, and thank you for listening.